Okay. So welcome to the, I think it's the 21st session, I think, right? Or the 20th, one of the two. Right? So welcome to that session. So I had a holiday, actually I had a holiday, and then sort of things, I got used to not doing any teaching for you all. Then finally, due to various requests, I thought might as well start, right? So few other requests that were made was to do twin pregnancy, but I think I will just do a gynae and obs topic like that. So let's do twin pregnancy, and it won't be a long sort of discussion. So I'll take you through the basics of a twin pregnancy and what you all need to know, right? Now, it's actually not twin pregnancy. We need to talk about multiple pregnancies, right? So which is more than 2 or more fetuses inside, right? So now if you look at twin pregnancies, they are mainly divided into 2, right? So that is, we are talking about zygosity. Zygosity means from how many zygotes the rest of the babies came into the womb, okay? So if one zygote divides, right, then you have a monozygotic twin pregnancy, okay? And if there are different zygotes, which means you have one sperm, one egg separately, and then you have another sperm, another egg separately. So those are different. So the completely the DNA and the genetic setup are different in these zygotes, right? So that is a dizygotic. Monozygotic is that one zygote, which means one sperm, one egg, divides and causes twins or multiple pregnancies. So that is a monozygotic, right? So that is something that you need to understand. So dizygotic means 2 sperms, 2 eggs, or 1 sperm each for each egg, and they are separate. Monozygotic is 1 sperm, 1 egg, and that divides to form multiple fetuses. Okay, so that is zygosity. The other 2 things that come up in these are chorionicity and amnioticity, right? So what is chorionicity? Basically, chorion means the placenta. So depending on how many placentas the pregnancy has, it can become, you can have 1 placenta, 1 chorion, 2 chorions, 3 chorions. So depending on how many placentas it has. Okay. So therefore, if there is 1 placenta, it is basically a monochorionic pregnancy. If there are 2 placentas, that means it's a dichorionic pregnancy. Okay. And trichorionic depends on how many placentas are there, depending on how many fetuses are there, you can have those, but those are extremely rare. So basically we have monochorionic, 1 placenta, and dichorionic, right? Amnioticity, or how many amniotic membranes are there, right, will tell us about the amnioticity of the pregnancy. So it is, if there is 1 membrane, that is monoamniotic, and if there are 2 membranes, right, that is diamniotic. So depending on that, so if there are 1 sac, that is monoamniotic. If there are 2 amniotic sacs, that is diamniotic. If there are 3 amniotic sacs, that will be triamniotic, and so on and so forth. You all understand? Right. So if there is a dizygotic, that is 2 separate babies from 1 egg, 1 sperm, 1 baby, 1 egg, or different egg, different sperm, 1 baby. These cannot fuse together. They have to have their separate placenta, which is chorion. They have to have their separate sac, which is an amniotic, monoamniotic, and the other has to have it separate. So basically, if it is dizygotic, it is always dichorionic, diamnionic. It can't be anything else. Do you all understand, children? Right? So that is something which you need to remember. Right? These are just basics which I just want to, I'm sure all of you all know it, and it's quite boring for you all since you all look very, very, very educated. But so that is the basic part, right? The second thing that you have to understand is that monozygotic or one zygote, depending on when it divides, can become different things, right? So the division of this one zygote into two, depending on the time, will give us different things, right? If a zygote is formed, this is now we are looking at a monozygotic pregnancy, okay? And in the first 3 days, if it separates, genetically it is the same almost all the time, right? Not all the time, but there are sometimes one X chromosome can travel here, right, with the Y, and one X can be left here. So that is very rare. Don't worry about that. So if they separate initially in the first 3 days, what happens is they go their different ways and form their own placentas, and they form their own membranes. Okay, they are separate, right? So therefore, in the first 3 days, in monozygotic twinning also, you can have dichorionic, diamniotic twins. Do you all understand? Because they are gone their separate ways. Same thing divided, but it divided early. So they were sort of like two different babies. Actually, but the genes are the same. Okay. So therefore, they are always identical, right? Because it's the same zygote that divided. Okay. Then if they divide between 4 and 7 days, right? Okay. So in that instance, most of the time, you have one placenta because it has already implanted. There's no time for it to divide. Okay. And then, but there's time for it to form two sacs. So it becomes monochorionic, diamniotic. Okay. And then if it starts to divide from about, say, after about 7 days, from 8 days or so, 8, 9, 10, 11 days, then what happens is there's no time for it to separate membranes. It is divided, right? And therefore, both babies will be in the same sac. And you get what? Same placenta anyway. And you get both fellows in the same sac. So you have a monochorionic, monoamniotic twin pregnancy. Do you all understand? And then if they start to divide after 13, 14 days, what happens is the division is not complete. And you end up with what? Conjoined twins. Do you all understand? So basically, this is something that you need to understand as the basis, right? So those are the basic genetic factors or genetic division that you need to understand. So I hope that's very clear, right? So let's look at overall, right? If you look at dizygotic twinning, right? Which means 2 eggs, 2 sperms, or twins or multiple pregnancy. So there are different genetically different babies, right? Throughout the world, this is dependent on the ethnicity, race, age, type of population, right? So it changes. And apparently it is the highest in the African countries, of which the Nigeria is supposed to be the highest. There's about 40, 42 per 1,000 births, is all dizygotic twins, right? So if you all were born in Nigeria, there's a 4 in 10 chance of you being or you having another twin. But it might be different because it is dizygotic, right? When it comes to Japan, of Asian countries that are the lowest dizygotic twin rates, right? So about 6 in 1,000 live births. So if you were born in Japan, the chance of you having another twin is very small, okay? And so on and so forth, right? In the American population, in the USA, because there are so many ethnicities put together, so they are somewhere in the middle, because it's also a mixture, right? So that is a dizygotic twinning. So it is not the same. So there is a genetic predisposition depending on the race, the population. You can have different rates of dizygotic twinning. Is that clear, children? Right. However, strangely, monozygotic twinning or twin pregnancy or multiple pregnancy seems to be constant throughout the world. It does not seem to be dependent on the population or the race, whether you are African, whether you are Asian, whether you are Caucasian, right? So it seems to be the same throughout the world. So that is something that you need to remember when we speak about these pregnancies, okay? With time, what has happened is that multiple pregnancies have increased. The reason being is the advent or the start of what? The start of in vitro fertilization methods or assisted reproductive techniques. And therefore, as you all remember, for assisted reproduction, we stimulate them. So therefore, there are multiple eggs. And therefore, there is a possibility that there are multiple pregnancies. Also, we take embryos and then we put them in the uterus, right? So if you put in 2 embryos, or if you transfer 2 embryos, there's a possibility you can have 2, or even when they divide, you can have 3 or 4, which you all are aware. Sometimes recently also in Sri Lanka, there was I think 5 babies were born, right? So all these are due to the fact that even if you put in 2, they will also divide among themselves, right? And then you get 3 or 4 or 5. So the chance of having multiple pregnancies has increased with the advent of in vitro fertilization. Suggests that 1 in 5 of all IVF pregnancies are multiple pregnancies, right? That's quite a lot, 20%, okay? While in the normal world, right, you will get about 1 in 80. On average, about 1 in 80 are multiple pregnancies. You all understand? So there's a huge increase in the chance of multiple. Therefore, because multiple pregnancies are always a risk, right, for the mother and the baby, and therefore now policies are coming in already in some countries. Policies are all where in vitro fertilization you can only transfer 1 embryo, right? So it's a single embryo transfer which is done, right? Okay. So, but different countries can choose differently, but that is the aim is to at least to try and reduce the multiple pregnancy rates up to about 10% in all these IVF pregnancies, right? Not 20%. They aim to reduce it to about 10%. Is that clear? Right, one moment. Right, sorry. Right. So let's now overall look at the why are we so worried. So now you have an overall view, right? In summary, you have a view as to what chorionicity what aminosity what zygosity right? The general distribution of dizygotic twinning and the monozygotic twinning, right? Is that clear? Now, why are we so worried about all this, right? Because there are maternal risks and there are fetal risks. The mother is at risk and the baby also is at risk. That means the baby also has problems and the mother also has problems. So if you look at the mother's risks, what are the risks that we speak about? Almost everything, right? They have more vomiting. Obviously, if you have one, you vomit. If you have two, definitely, probably you need to vomit more. Okay, right? So there is more emesis gravidarum, and hyperemesis is excessive vomiting. So you have hyperemesis gravidarum. Obviously, because there are two inside or multiple pregnancies, there are more miscarriages, right? So there are more miscarriages. 3, there are more chance of the woman going into preterm labor. As you all understand, the higher the order of pregnancy, the higher the chances that the woman is going to go into preterm labor. So much so, in triplets, the average, almost all of them would have gone into labor about 32 weeks, right? So the higher, so preterm labor is higher. At the same time, the chance of preterm labor is higher. The chance of growth restriction, or that is the baby's raise. I'll talk to you that later. So also the chance of the mother having polyhydramnios a lot is higher. The chance of the woman having diabetes is higher. The chance of the woman having anemia is higher because the demand is higher, right? The chances of, as I told you, antepartum hemorrhage or abruption is high. The chances of postpartum hemorrhage is higher because there is distension and the uterus do not contract very well after delivery, because as you all know, the mechanisms to stop bleeding is violent contraction at the end, and it closes all the blood vessels that are coming into the placenta very much, right? So, but when there is over distension, the chance of it doing the contraction and preventing PPH is less. At the same time, the chance of pregnancy-induced hypertension or preeclampsia is higher, right? Due to the fact that there may be more placental problems. Remember, preeclampsia is a placenta problem. So therefore, that is also higher, right? And at the same time, even after delivery, the psychological problems may be higher because it's very difficult sometimes, let alone one baby, then the woman will have 2 or 3 or even more, right? So there will be more depression and psychosis. And at the same time, there will be more breastfeeding problems, right? Because you have to feed multiple babies, so there will be problems there as well, right? So these are the things that the woman will have, right? To recap, hyperemesis, chance of miscarriage, preeclampsia, anemia, antepartum hemorrhage, postpartum hemorrhage, right? Diabetes may be higher, right? Then postpartum depression or psychological problems, then breastfeeding problems, right? Sepsis may be high. So all these entities, preterm labor is high. So all these will have problems for the mother. Is that clear? Right. Now, going from that, let's go on to the main problems that the baby will have. So we will just give the what is this? We will discuss the what is this? What the baby, what the problems will have, right? So somebody has going in chat, right? Yeah, placenta previa. Yes, placenta previa. Abnormal placentation, of course, its position may be higher because depending on, because there are, if there are two placenta, then of course one cannot be somewhere which may be a placenta previa or abnormal. So that's correct, right? So let's look at the baby's problems. The biggest problem, right? The biggest fetal risk is what? The chances of the baby dying inside the uterus, right? Or intrauterine. So, but of all those, the biggest problem of all for babies with multiple pregnancies is preterm delivery, right? They tend to come out earlier. So when there's preterm delivery, the baby is preterm and the baby has all the problems of a preterm infant. The lungs are not mature, the organs are not mature, and therefore the baby can have, there may be problems with oxygenation, there may be problems with breathing, there may be problems of infections coming in, there may be problems of breastfeeding. All these problems will come up with this. The second problem is, of course, the chances of the baby dying inside is also high. That is, the intrauterine death is high. At the same time, once the baby is born, the chance of the baby dying as a neonate is also high. So overall, intrauterine death and neonatal death, intrauterine morbidity and perinatal or neonatal morbidity is higher in every way for multiple pregnancies as opposed to a singleton pregnancy. Is that clear, children? Right. So that is now. So if we take those one by one, let's look at the problems one by one, because you all may be requested or asked in your exam or that what the problems are that the baby is going to face or the babies are going to face itself, right? As I told you, the chance of, now I have told you already, the chances of dying in utero is higher. The chances of the baby having growth problems, right? Intrauterine growth restriction or small for gestational babies chances are higher, right? The baby dying outside or neonatal death is higher. And most of it is, remember, due to what? Is due to preterm delivery. Okay, right. So the second problem that we need to be aware of, right? So let's talk about specific of all these. Most of the problems are in monochorionic twins, right? So as I remember, all these are monozygotic. So we'll do that. Most of the problems are in monochorionic twins. So the monochorionic twins, the biggest problem is that other than the, remember I told you, if they divide initially, if the monozygotic ones divide initially, they will have two different personalities. So you have monochorionic, diamniotic. Those are okay. But the biggest problems are with what? The monochorionic, diamniotic, and the monochorionic, monoamniotic twins, right? So those are the problems that we face or the babies face all the time, right? So for this specific problem, the problem is in monochorionic diamniotic and monochorionic monoamniotic, they share the same placenta, right? Because if it is dichorionic, which means two placentas, diamniotic, they have their own placentas. So as if they are living in separate houses. But here, right, when we have monochorionic diamniotic or monochorionic monoamniotic, basically they share the same placenta. Now, when that happens, when they share the same placenta, remember, for the perfusion, there are lots of things that are going on in the placenta. So there are anastomosis between these placental blood vessels. So there are arteriovenous and venous arterial blood, or basically arteriovenous anastomosis. So from the artery, blood is shunted to the veins. Then there are arterial anastomosis. Between arteries, there are anastomosis. And there are venous and VVS. Between veins, there are anastomosis, right? If all these are well developed, right, the chance of having a problem is small. But the problem comes sometimes when there are lots of arteriovenous anastomosis, but the arterio and the venous are not very well developed. So basically what happens? In the whole system, between these two babies, because there is a existence of arteriovenous anastomosis between this in the shared placenta, the blood gets shunted or thrown into one because the arteries have more pressure and the veins have less pressure, and therefore there's a shunting of blood from one to the other. And I'm talking about, mainly I'm talking about monochorionic diamniotic twins, right? So what happens is, when this happens, if underneath that, right, not in the superficial, underneath or in, if the arterio and the veno anastomosis are developed, then this shunting of blood from one artery or other, that is from the arteriovenous anastomosis, is nullified. So artery throws some blood to the vein, no problem. The vein throws blood from the other vein, right? And then because there are artery throws from the vein, but then from this artery, it will compensate and send the blood to the other one. So usually there's no problem. So in those fetuses, problems don't develop. However, when there's well-developed arteriovenous anastomosis, but less developed arterio and veno anastomosis, the two babies can have problem. One fellow will start to receive a lot of blood, while the other fellow, right, is going to shrivel. Okay, one fellow becomes small, the other fellow becomes big. So what is that called? That is called twin-to-twin transfusion syndrome, or TTTS, right? So as things go on, what happens is one fellow becomes small or small for gestational age, or there's growth restriction. The other fellow becomes large because it's getting a lot of blood, right? So, and the other fellow becomes like a hydrops fetalis, right? So therefore, as time goes on, right, in one fellow, the amniotic fluid will shrink and the membranes will stick to the fellow. In the other, there's a lot of amniotic fluid. The baby will become large. The bladder becomes large, right? There is fluid in the cavities. The heart becomes large. There's fluid in the abdominal cavity. There's fluid in the a lung, around the lung, right? Around the heart, around the tummy. The bladder becomes large. So basically, and there's a lot of amniotic fluid around it. So basically what happens is one twin will die because of the restriction of fluid or restriction of blood into that. It will die of small for gestation, and the other fellow will die of heart failure due to the excessive amount of fluid that is coming into the baby. Is that clear? So that is the problem in the twin-to-twin transfusion syndrome, right? And we don't see that in most of the time in other one. It's usually due to in monochorionic diamniotic, but rarely so in monochorion or monoamniotic, because they are in one sac, and usually therefore the placenta is more sort of developed with two days. So therefore the sharing is better, right? So therefore in monochorion or monoamniotic, we do not can get, but very rarely we get this twin-to-twin transfusion syndrome, right? Then there's another entity which is called twin reverse arterial perfusion syndrome, right? Where what happens is there are more arterio anastomosis, right? So what happens is, now remember, arteries in the placenta carry deoxygenated blood. So when there's a lot of AAAs, arterio anastomosis, one fetus gets a lot of deoxygenated blood, and that prevents it from developing further. So it becomes just like a lump, right? And it's called an acardiac twin, right? Most of the organs do not develop very well. It just becomes like a lump of flesh, right? Because it is all the time it's getting deoxygenated blood from the arterio anastomosis. Okay, so one twin pumps all the time. It sends blood to the other one, while the acardiac twin, right, is still sort of a living lump, but it takes blood. So therefore, this discordance can cause problems to the bones, right? So therefore, that is something that can happen very rarely, but there is also a problem that can happen. Got it? So that is called a twin reverse arterial perfusion syndrome. And out of all these, there's another one which has been recently spoken of, which is called the TAP or TAP syndrome. What is that? Twin anemia, polycythemia, Sweetgrams. Okay. TAPS, right? This is a new entity. It's not that. Earlier, maybe it was there that twin-to-twin reverse, twin-to-twin transfusion syndrome. Sometimes the reversal of the shunts cause this TAPS. But now it is being described as a separate entity, right? It is called twin anemia polycythemia sequence. How does that happen? It is thought due to very small vascular anastomosis in the placenta between these two fellows, right? For some reason, there's a mismatch in the amount of blood that is being exchanged. So over a long period of time, what happens is one baby, although there's no apparent difference in the amniotic fluid volume in both, they are both having normal amniotic fluid volumes, right? The amount of fluid that is getting into both is apparently the same through the blood. However, due to very small vascular anastomosis, there's a preferential movement of red blood cells into one, right? While for some reason, the other fellow does not get the red blood cells. Okay, so one fellow becomes anemic in a normal amniotic fluid sac, while the other fellow gets polycythemic in a normal amniotic fluid sac. Do you all understand? Right? So this is a new thing that has been. So what happens is, usually it is not diagnosed. When the fellow comes out, one fellow is white, other fellow is red. So the red fellow is the polycythemic fellow, the white fellow is the anemic fellow. Right? However, if you want to diagnose that in utero, you will have to do a Doppler of the middle cerebral artery of the baby. And what does that say? The Doppler means you measure the blood flow. In an anemic fetus, the blood flow is very fast. Remember, the blood is thin, and therefore the blood goes very fast in the middle cerebral artery. Depending on the Doppler, you can say how much or how anemic the baby. While in the polycythemic fetus, the blood flow is slower, right, in the Doppler, and then you can say, okay, there is. So if you do that somewhere in the middle, then you can diagnose a TAPS or TAPS, right? So these are the three specific things, children, that you need to know about specific problems. What are these again? Twin-to-twin transfusion syndrome, right? And that is due to what? Mostly arteriovenous anastomosis, which are predominant, while there is less venous to venous anastomosis and less artery to artery anastomosis. So therefore, blood gets shunted into one. Then very specific one is what? TRAPS, twin reverse arterial perfusion syndrome, where there is a lot of venous artery to artery anastomosis. Artery to artery is deoxygenated blood. They get shunted to one twin, and therefore an acardiac twin forms while the other fellow is there. So, however, if depending on this, the normal baby also can suffer and die. And the third problem is, which is a new entity, which is called TAPS, right? Which is called due to small vascular anastomosis, there's a mismatch in the distribution of the red blood cells. So one fellow becomes anemic, the other fellow becomes polycythemic. So it's called the twin anemia polycythemia sequence, right? And that is also a known problem. Is that clear, children? Right. So these are the things, perhaps few things that you need to know about the specific things. Okay. So the fetuses have higher, in all multiple pregnancy, has higher chance of dying inside. The higher the chance of having a neonatal death, the higher the chance of being preterm, the higher the chance of having a small for gestational age. That is for all twins, okay? But more so in monochorionic twins. And then specifically for monochorionic twins, right, we have the TTTS, we have the TAPS, and we have the TRAP. Is that clear? So those are things that you need to remember. Okay, so now let's go. I have a question. In TRAPS, does the normal fetus have fluid overload? And yeah, so there's a possibility that the normal fetus can have fluid load, but the distribution is very individual. So some of them might have a lot of fluid, some of them can go into heart failure, right? So it depends on the fluid distribution in that specific problem, right? Next. So the chances of preterm labor. Remember, the higher the, now I'm not speaking now of specifically of monochorionic only, okay? Remember what we have spoken, those are very specific monochorionic problems. Now I'm going on to general multiple pregnancy, right? Then we have to look at preterm labor. Yes, there is a higher chance of preterm labor. Higher the order, the higher the chance of preterm labor, right? Of those, the chances of going to preterm labor is less in dichorionic diamniotic twins. The chances of going into preterm labor is more in monochorionic diamniotic and monochorionic monoamniotic twins, right? And the higher the, not twins only, not the chorionicity only, the higher the order of pregnancy, if there are 3, 4, 5, 6, 7, or so on, the chances of going into preterm labor becomes higher and higher and higher as the order increases, right? For example, for triplets, most of them would have gone into labor by about 32 weeks, right? So therefore, the chances of them going to preterm labor is higher. Now, as you remember, if they go into preterm labor, the chance of problems for the babies are also higher, right? The next thing is, now can we predict these women who are going into preterm labor in multiple pregnancy? Remember, a cervical length of 3.8 centimeters at about 22-23 weeks tells us that the chances of the woman going into preterm labor is less. Any woman in singleton or multiple, right? So if we measure the cervical length around 22-23 weeks, right? And then finding a cervical length of more than 3.8 centimeters, right? That is based on evidence. The chance of the woman going into preterm labor is less. However, in a singleton pregnancy, if you measure the cervical length at 22-23 weeks, and you get a value of 2.5 or less, the chance of that woman going to preterm labor is pretty high. However, 1.5 centimeter. If you get a, in singleton pregnancies, if you get a cervical length of 1.5 centimeters at 20-23 weeks, there is a good chance that the woman might go into preterm labor. That is for the prediction of singleton pregnancies. Now for multiple pregnancies, at 20-23 weeks, if you measure the cervical length, remember the cervical length is from the internal os to the external os, right? Not what is inside the vagina only. If you measure that and you get a value of 2.5 or less, then chance of, there's an 80% chance that the woman can go into labor by 30 weeks. So one way of predicting preterm labor and getting prepared for it, right, in women with multiple pregnancies would probably be looking at the cervical length at 22-23 weeks, right? However, preventing the woman from going into preterm labor, like giving progesterone, doing cervical cerclage, and all sorts of interventions, still there is no evidence for us to, use this to prevent these women from going into preterm labor. But the prediction is possible in certain women whose cervical length is less than 2.5 centimeters at 22-23 weeks in multiple pregnancies. Is that clear, children? Right. So yes, if they go into preterm labor, of course, either we have to deliver them, right? And remember, if there's a chance that they might go into preterm labor, then we need to give them targeted steroids to try and improve the neonatal outcome. Just to remind you, what are things that we can do, try to do? Yes, we can try to give progesterone, do a tocolysis to reduce the contractions, give the steroids so that they work for at least hold on to the labor and they're not letting the woman go into labor for 48 hours till the steroids work and then let them deliver. That is number one. Number two, for neuroprotection of the brain, you can use magnesium sulfate, right? during and just before delivery. That gives neuroprotection brain, and that can reduce the amount of cerebral damage due to extreme prematurity and hypoxia of the fetus. So those are the two interventions that you can do if the fellows are coming out earlier, right? Right. So that is our discussion about preterm labor. The next thing we have to remember is small for gestational age. The chances of one or both having growth restriction is very high as opposed to singleton pregnancies, right? So much so, for us to diagnose, we can use the normal charts, right? For small for gestation age. And of course, we have to be on the lookout for the discordance of growth. One is becoming bigger and the other is small. So then we have to be aware, oh, look, this fellow must be having some problem or a small for gestation age fetus. And what is the cutoff marks we go? If there's a discordance of more than 25%, right, between the two twins, when you measure by ultrasound scans, right, then we need to be thinking about one fellow having growth restriction while one fellow might be not, right? And therefore, the one who is having growth restriction is at a higher risk of having problems, or especially intrauterine, maybe death or other problems, right? So remember the discrepancy more than 25%, there's a possibility that we are looking at a fetus who is having small for gestation age while the other is growing normally. Okay, so that is one which you need to remember, right? Small for gestation age in one twin, or sometimes in both twins. Very rarely that's a possibility. Right? The next part, what we have to remember is the chances of, so I have spoken about small for gestation age now, right? The chances of them having. The next thing is intrauterine death. Now, death of one twin, that is a complication or a problem, can cause problems to the other twin, right? Especially in monochorionic twin pregnancies. Why is that? Because when one twin dies, because the placentas are connected, there is immediate hypotension, right? Because one fellow dies, and the other one's blood pressure also can drop, and therefore can cause cerebral damage and other problems, right? And sometimes there is cerebral vacuolation, cerebral palsy, and the second twin also can die. So therefore, intrauterine fetal death of one twin, right, can cause problems to other. So it's a very, very problematic thing, because there's very little ways where we can diagnose problems in the other twin if the other one dies. So usually, if the death has been diagnosed within 24 to 36 hours, we need to decide whether we need to get the other twin out. If it is more than 36 hours, maybe already the vacuolation and the brain damage has occurred due to intense hypotension, and therefore maybe sometimes it's very, very controversial what to do, right? In other countries, sometimes if brain vacuolation occurs of the remaining twin as diagnosed by ultrasound scan or MRI, sometimes fetocide may be carried out if the period of gestation is small, right? So those are the problems that can occur. So it's a very controversial topic. Sometimes one dies, the other is not affected, it can be allowed to go. Sometimes one dies, the other also dies. Sometimes one dies, there's cerebral damage to the remaining twin, right? So it's very, very controversial. It all depends on the period of gestation it happens, right? And therefore, these are all very, very individual decisions that must be taken if one twin dies in utero, right? Now I forgot something about the discordance of twins. Usually it is recommended that we start to do growth scans for dichorion or diamniotic twins from about 20 weeks, right? And we start serial growth scans in monochorionic diamniotic or monochorion twins from about 16 weeks to find out whether there's a discrepancy in growth. Okay, So if we start to have see a discrepancy in the growth, remember estimated fetal weight can be calculated by ultrasound scan by looking at different parameters, right? Which are, as you all remember, head circumference, biparietal diameter, female length, and the abdominal circumference, right? Usually, when a discrepancy starts to occur, or if we diagnose TTTAs or TAPs or anything, normally they'll be sent to a fetal medicine center for specialized management of these twins, right? And especially if you want to, so you can, if the discrepancy starts to occur, remember if there's a 25% discordance between the growths, then you might need to refer them on to a fetal medicine center to look after these babies, right? Right. So what are the other problems in twins? Now, there are other specific small problems, not small, I mean problems that can occur, which are due to specific. For example, for monochorionic, monoamniotic, one placenta, single sac, they can get cord entanglements, right? Because they are swimming in one sac. So they will go this and that, and then all they get cord entanglements, which, you know, there can be, the one baby can die, right? The second thing is because they are sharing one place, right? They can get all sorts of problems due to pressure. Sometimes the limbs may be deformed, right? Talipes, all those can happen. And also, the other one problem is fetal anomalies are higher in multiple pregnancies, right? The chances of neural tube defects, cardiac anomalies, right? Bowel atresia, differences in the kidneys, right? All these anomalies is slightly higher in pregnancy. In dichorionic diamniotic, it is less, while in monochorionic monoamniotic twins, the chances are slightly higher, right? Okay. So therefore, these are the problems which you need to understand about what the babies in multiple pregnancies, what problems you can have. Is that clear? So that, I think, gives you a comprehensive understanding. So if you about the problems that, so I have spoken about children, what? To summarize again, we have spoken about chorionicity, about the amniocity, we have spoken about the what is this amniotic, chorionicity, and zygosity, right? I've spoken about the general population that dizygotic twinning is variable and depending on the race, ethnicity, while monozygotic twin is generally the same throughout the twin for unknown reasons. Then I have spoken that IVF has caused an increase in the twins, right? To such an extent, people are now recommending single embryo transfer to try and get the twin pregnancy down because of its complications and multiple high order births. I have spoken of the maternal risk, right, which I have spoken to you. And now I have spoken comprehensively about the fetal risk, right? The small for gestational age, intrauterine death, the neonatal deaths, right? Then I have spoken about very specific problems that the babies can have in monochorionic twins, right? What are these? The TTAs, TAPs, and the TRAP syndromes, right? And I have spoken to you about the small for gestational age, about preterm labor, right? And the chances that there may be more fetal anomalies in this way, right? Is that clear, children? Right. So those are the things that you need to know. Then let's talk about the diagnosis. If someone comes with one of the more major things that you need to try and discover is whether it is monochorionic or whether it is dichorionic, right? And what does that say? Whether basically whether there are two placentas or a single placenta, right? Which is supplying the twin pregnancy. So one of the usual signs, especially in the first trimester, diagnosis is almost 100%. One of the useful signs to do would be to check for the lambda sign. Lambda sign is basically if there are two placentas, and because the membranes are nearer to each other, right, the placentas tend to grow on to the amniotic membrane. The chorions seems to grow on to the amnion. So what is that? So it becomes like a lambda, or it is a thick, right? So therefore, usually when you see the lambda sign, or it's called the twin peak sign sometimes, what happens is what? You are looking at a dichorionic diamniotic pregnancy, right? Of course, if you see no separating membrane, then it is monoamniotic, right? And therefore, it has to be monochorionic, right? So therefore, one of the things that help us is to do a ultrasound scan in the first trimester, especially on 11, 12 weeks. As time goes on, beyond 12 weeks, close to 18, 19, 20, the chances of you diagnosing that drops down to about 80%. So that is not very accurate. Well, there are other things which you can do. You can do gene studies, but that is very difficult, right? The other problem is that when you are monitoring these babies, to check whether there are genetic abnormalities, you might need to do gene studies and screening for Downs and all that. These are all very controversial because there are 2 babies, right? In which case, of course, you will have to make sure, map the babies out, do separate amniocentesis, and take cells from each and do genetic studies. But then you have to be sure, right, for screening, that this came from this baby and this came from this baby, because if the results show Downs in one and another problem here, then when you go back and then you are not sure which is which, right? So therefore, you need to do mapping of the babies, which are done in fetal medical centers, and then a proper separate analysis of both should be done. So normal bioscreening, biology screening is a bit difficult, right? And therefore, we have to remember that screening may be a bit dodgy and controversial in twin or multiple pregnancies, right? The other thing we need to remember is what we call the T sign, right? I think there was a question, I just saw it pop up, right? See, in monochorionic pregnancies, since the placentas are not traveling, there are no 2 placentas, right? The separation of the membranes will be like this. So basically, it comes like a 90-degree or the T sign, right? While in, so that would tell us that it is a monochorionic pregnancy. While, as I remember, in dichorionic, there's a lambda sign. The membrane or the chorions are thick, and they travel on to the membrane. So therefore, you get a thicker sort of place where they meet, right? So that is called the lambda sign. So that is one way which you diagnose monochorionic or whether it is dichorionic, right? Because if it is dichorionic, most of the time, then you are okay, because there are most of the problems are not there, because monochorionic has its own very specific problems, which I have spoken to you all about, right? All right. So let's look at how we manage these pregnancies, right? So as I told you, once the diagnosis is arrived at and when the counseling has been done, so it is just basically monitoring. So you monitor along the way. Remember, in monochorionic pregnancy, you start from 16 weeks about the growth, and then in dichorionic, usually you start from 20 weeks, and you can do it. In dichorionic, you can do growth monitoring every 3 to 4 weeks. In monochorionic, it's better to start from about 16 weeks and do every 2 weekly scans to see whether there is a growth discordance or whether you pick up a problem, right? And most of the problems, if they do occur, we might need to, if all these specific problems occur, we might need to refer them on to a fetal medicine center, because that will give the best chance for these babies to survive, right? Now, how do we treat these specific problems if they do occur? If there's twin-to-twin transfusion syndrome, what happens is, usually in Sri Lanka, it's done. You do laser ablation of the arteriovenous anastomosis, right? So when there's laser ablation is done, right, between these two, the shunting will stop. And if it is done early, you might get good results, because it is as if we are separating, making this one placenta into 2, and we are separating the blood supply to these 2, right? So it is done in specialized centers. We in Sri Lanka also we have that. So, and the laser ablation can be done. So sometimes it can be useful. Very rarely, septotomy. The membranes between these two are broken so that the amniotic fluid will run, but that will not prevent the actual blood supply through the umbilical cord. So the problem might anyway continue, right? So other thing is serial amnioreduction, but laser ablation of these vessels between these two gives the best results, right? And therefore, serial amnioreduction is usually done where, because if usually done in places where there is no laser for us to ablate the arteriovenous anastomosis, right? So that is one thing. Now, for example, for the TAPS, that is twin anemia polycythemia syndrome, what are the ways which you can save the anemic baby might be for intrauterine transfusion into the fetus that is having problems. And also, there's also possibility in twin-to-twin transfusion syndrome also, sometimes specialized centers, they might try to remove amniotic fluid one and transfuse to the other after the separation. But different problems, those are very, very specialized management, which you need to understand can be done only at specific fetal medicine centers, right? Okay, now, if we, so that is sort of the overall management and the problems. Now let's look at the timing of delivery of twins, right? So that is something that you will need to understand. Usually in dichorionic diamniotic twins, delivery is recommended at 37 completed weeks. Okay. And in monochorionic diamniotic twins, delivery is recommended at 36 weeks. Right? In monochorionic monoamniotic twins, the delivery is recommended around 32 weeks because otherwise they will have cord problems. You all understand? For triplets, usually delivery, if there are no problems, delivery is recommended around 35 weeks, right? And then so on and so forth. But for all the other problems which I spoke, if there is small fogastage death, intrauterine death, right? TTA, straps, all these things, then of course, specifically individually, you need to take the decisions as to what you want to do, right? So do you all understand? That is the timing of delivery. Remember, for both monochorionic monoamniotic twins or monochorionic diamniotic twins and dichorionic diamniotic twins, right? If you carry the pregnancy beyond 38 weeks, the chance of intrauterine death becomes higher, right? So that is something you need to keep in mind. So and therefore, what is the take-home message? Normally, we do not carry pregnancies or allow the pregnancies to go more than 38 weeks in both. So remember, dichorionic, diamniotic, we deliver by 37 weeks. Monochorionic, diamniotic, right? We deliver by 36 completed weeks if there are no problems in between. And monochorionic, monoamniotic teams, we tend to deliver by about 32 weeks, all with steroid count. Okay, right? So that is the timing of delivery. So now let's look at the mode of delivery. Mode of delivery, remember, if it is vertex, right? We can allow a vaginal delivery to take place because it acts in the pregnancy. It is like a singleton pregnancy. So the first baby will come out and then the second baby will come out. The only problem during labor is what monitoring. So sometimes if it is vertex, you can fix a scalp electrode onto the baby's head and monitor that separately, the one that's coming out first. And then you can do a normal abdominal probe for the cardiotograph for the second baby. So monitoring always becomes a problem during these multiple pregnancies or labor, right? Then when there is vertex first and a non-vertex baby, the second, then the delivery is a bit controversial, right? The first fellow, there's no problem in doing a vaginal delivery. But the second fellow, whether we do a vaginal delivery or whether we do a cesarean section, is a matter of choice. So therefore, that needs to have an individual decision. Of course, in the second of twins, if it is properly aligned and breech, then it can we can perform a breech delivery. If it is properly aligned and it suddenly turns onto carefully, we can do. If it is transverse line, then there's a controversy. I'm talking about second baby, right? Whether we need to turn it and then deliver it, or whether we go for a cesarean section. So that can be individually decided at that time about the delivery of the second twin in non-vertex position. Is that clear, children? Right? So vertex to vertex, vaginal delivery. Vertex was then non-vertex or even breech, right? Then of course you can try either way, because if first baby will come out, but the second of twins in a non-vertex position, we have to decide what to do. So vaginal delivery or cesarean section, right? If the first baby is in breech, if it is breech, most of the time it is recommended that we go for a cesarean section, because even for a primary breech, we might go for a cesarean section also. That is also controversial. But if it's two breaches, then it's better to go for a cesarean section. If it is first one is breech while the other one is cephalic, very rarely you get what is called the heads might lock. Okay, it is the first one and breech head, and this other one heads might get locked. So rarely, normally, if it is breech and cephalic, first one is breech, second one is cephalic, we might plan to go for a cesarean section, right? And multiple order, triplets, 4, 5, 6, 7, usually the clinicians will opt for a cesarean delivery, right, than to go for, although some centers might try normal deliveries because the babies are small, so they will come out, right? But however, usually most centers will opt for cesarean delivery in higher order multiple pregnancies, right? So during labor, the biggest problem is monitoring, right? So which we have to understand. So monitoring may be a problem. So therefore, we have to, sometimes the scalp electrode is used to monitor the first baby during an vaginal delivery, right? So that is about delivery. The next thing which I wanted to understand is the management of labor, which I will give a very 5 minutes discussion about how to manage a labor with the first in the vertex, the second in a non-vertex, if you are going for a vaginal delivery, right? So what we do is we'll allow the labor to progress. Oxytocin can be used as usual, like a singleton pregnancy. And when the first baby is delivered, you clamp the cord, right? And then once you clamp the cord, the baby is handed over to the pediatrician, right? What we do is, first of all, we will do a careful vaginal examination, right? And we feel what is there. Okay. So if we feel the head, then of course there's no problem. So the labor will slowly restart in about 20-30 minutes. And then once the head is well established, then you can do an artificial rupture of the membranes and allow the labor to progress. Okay. And then when you do vaginal examination and combine vaginal abdominal examination, if you feel that it's a breech, right, and it's a flex breech, then of course you will allow the breech to come down, right, so that and you can rupture the membranes once the breech has come down well, or let the membranes rupture on their own, and then you can do a vaginal breech delivery if you want. Or if your unit policy says, okay, go for a cesarean section if the second twin is in breech, then you go for a cesarean section for the second of twins, right? In the third instance, when you put the check abdominal and if it's a transverse line, right, the membranes are intact, then we have an option, two options. From above, we do it's called external cephalic version. So with the hand in the vagina and that also we can sort of version it, position it to carefully position, right? And allow the labor to progress and rupture the mucus, right? And then it will deliver by careful, right? If it turns on to the, by an external recovery, if it turns on to breech and you get a breech, then either you can go for a cesarean section or you can deliver the baby, right, which is called breech extraction. So you put your hand in, right, feel the leg, right, through the membranes. Remember, the hand of the baby is like this, the leg is like that. So that is how you feel, right, through the membranes. Okay, there's a 90-degree angle, right? So kakula mehema nawanna bෑ හොඳේ සම්පූර්ණයෙන්. Okay, so අත පුළුවන් හොඳේ. හරි. So therefore then you grab that leg and you can do a breech extraction. So breech extraction is done by an expert, right? And therefore what you do is you slowly draw out both legs down and then you do a controlled breech extraction. So this is the only instance where a breech extraction is practiced for the delivery of the second twin if it becomes necessary. Okay. Otherwise, the other option is just simply to go for a cesarean section for the second of twins, right? So this is how practically that we go about looking for a twin pregnancy for the delivery. Of course, after delivery, as I told you, the mother can have postpartum hemorrhage, the mother can have later on, the patient can have depression, breastfeeding problems, all those need to be addressed in the puberty. Okay, so this is all which I wanted to tell you about twin delivery. I think that gave you all a comprehensive overview of what is what and what the, and overall we spoke about the mode of delivery, what we need to do in labor, right? So those things are there. So therefore that should give you enough basis for you all to, of course, to study more and gain more knowledge on that, right? Because this is another 30-40 minute lecture, which is not going to give you everything. So you can build on what I have taught you and get more information into your very educated and good heads. Okay, right. So let's just slowly look at the questions. How does hypertension occur in IUD? With death, immediately the blood pressure falls due to a release of factors inside. So immediately all the blood, there's venous arterial dilatation and everything falls. So you have severe acute hypotension. Please explain T sign. So I explained the T sign, that's fine. In multiple gestation, how do you use CTG? I told you, right? But if there are more, it's very difficult. Usually in the first one, you can fix a scalp electrode. And for the second one, you can do an abdominal probe. So that is how normally which you measure. So there are twin channels. So in each different cardiotomographs are good, right? So I think we have covered all the questions, right? So then next time, as I understand, I will do gynecology, right? And so I will try and do a class next week. It won't be Sunday, it will be, but I will let you all know in advance, right? And then we'll do approximately, we'll try to do one class per week. Okay. So that's all. Any more questions that you all want to ask me? Right. So everything understood. Okay then. Good night.
Good night, sir.
Thank you, sir. Good night.
Good night. Good night.